Thank you for being back from the coffee break. So we are continuing to the second session of our conference, which is distance and proximity in the use of healthcare. And I would like to call to the step Dr. Olieva, who is a member of Board of Directors of SPMS, EPE, Shared Services for Ministry of Health. Dr. Posiano, if I am pronouncing it correct. Olieva,
Yes, you did.
The step is yours.
Well, first of all, I would like to thank you for your invitation to the SPMS to be here with you to share our vision and what are we doing on digital and citizen-focused healthcare. As you will see along our presentation, we will have lots of very forwarded practices to show to you that we are very proud of and that we are honored to share with you. I will also would like to excuse Dr. Luís Góes Pinheiro by an unpredictable schedule appointment. He wasn't able to come here today, but and I will try my best to give you our vision, to share our vision, and expect you to enjoy it and to take advantage of our practices. My name is Ponciano Oliveira. I am an executive board member of the shared services within the Ministry of Health in Portugal. I am specialized in health and policies and health economics and policies. I have also a degree in law. I have also a specialization in hospital management, and well, on my on my previous job, I was more board member of the Northern Region Health Region in Portugal during 10 years, and before that, I was Deputy High Commissioner for Health within the Ministry of Health, and I will try to share our experience in the shared services as well as in the Ministry of Health. First of all, I would like to give you a brief presentation of what do we do. Our company is a public company, and it's we provide several shared services within the Ministry of Health. Our goal is to centralize, optimize, and rationalize the shared services that we provide, which are in the field of the human resources management, on finance, on public procurement, and we are the main provider of the ICT solution, information and communication technology solution for the ministry. About 90% of the solutions in these matters are supplied by our company. Regarding our country, we are about 10 million citizens. We have 54 public hospitals. When we talk about public hospitals, we are talking about either hospitals, either groups of hospitals. These are 54 public enterprises or institutes. Within the primary care, we have about 1,294 primary care units that are spread along the country, and as I told you, we have 90% of the ICT solutions that are provided within the Ministry of Health. These are only the public answers. We would have on the tertiary care, on the long-term care. We have lots of providers of the social sectors, and even in the acute care, we have also lots of partners, of stakeholders with the social nature or private nature. Now, talking about what are we doing in what concerns to the digital and proximity focus supplying of health. At this moment, our main vision is consolidated in what we call recovery and resilience plan. It was a plan that was designed by the European Union that has has a broader scope than the health care, and within the health care we have a special sector for the digital transition, and we are taking the advantage on these resources that were supplied in this program to scale up some solutions that we had, to innovate some other, and to create some other. These solutions are based on our experience, on on our inventory of projects, but also in the opportunities that were revealed within the pandemics and these last 2 years. We have structured our plan of our recovery and resilience plan in 4 axes. One is dedicated to the infrastructures, the other one to the professionals, the other one to the citizens, and the fourth one to the health data. As you can see, we are talking about the context of empowering the context that we need to work regarding the infrastructures. Then we are working on a new mobility operating system, operating mode or model of working for the professionals that is aligned with the vision that we have of today for the professionals working mode, and for the citizens in an omni-channel platform that is dedicated to provide to the citizens the same experience, however the channels that they are interacting with the system. You will see that we will have 4 channels that will permit that same experience for the citizen, and it will be an experience that will be increased with services, with proximity, and with easier ways or more friendly ways to approach the system. And then the 4th pillar is unavoidable, and especially for associations like yours, because it cares and it approaches the health data either for primary care, either for primary use, either for secondary use. We will work on elevating the quality of data, on enlarging the points of information that we can gather, and then in the security and the ways that and improving the ways that we can work or treat or process the information. In what concerns to the infrastructure's goals, well, as I told you, the goals are to improve, to increase the performance, to have the systems more available, to have much more capability of storage, because we are walking towards a new standards of data usage and resources and technology uses, such as artificial intelligence that need much more capability of storage, to rationalize the management, because as you must imagine, for instance, when we talk about investigations or innovation or development or research in what matters to the genome, for instance, we need large quantities of data, and therefore we will need not only much more capability to storage data, but also to rationalize the data that we have in order to make it more usable, and in order to promote also an ecological use of the ICT solutions, aligning with the ethical principles that are in these days defended and promoted by the European Commission. And we will also improve security and business continuity. We will increase our practices, our maturity, and our level of security in what regards to defend the structures, but also in what concerns to business continuity. This is also a matter that I think there's no need to explain why it is in the order of the day. Regarding the actions that are in course for the concretization of those goals, we are renewing our data centers and working stations. Well, regarding the data centers, we have at this moment two. We will have a third one, and we will. They are all implemented according with the good practices that are applied to the sector. Nevertheless, we need to elevate our standards of security in what regards to business continuity, and to have a second redundant infrastructure. We are also centralizing some infrastructures that are very dispersed that are very spread along the country. Our health system is divided in 5 health regions, and those 5 health regions have competences within a part of the operation system of the operations on the operational part of the information system, and therefore it is historical the growth that was implemented. It was on different levels, on different velocities, and therefore we are centralizing it in order to rationalize the databases, for instance, and also to get better performance and better usage of the data. And we are improving the business continuity plans in what regards to the processes of the work of the framework and the working processes. Our ongoing activities on these matters are the new information network. Well, we have a global network for the health system, for the health ecosystem, that we need to elevate the performance in order to have the capability of implementing those mobility concepts of work for the professionals. We are also renewing the local area networks, because it's another part of the process that can improve the availability of the network. And we are also renewing the professional personal equipment according with the specifications that are given us by the health professionals. In what concerns to the professionals, well, one of the things that we need is to have the professionals accessing the information that they need, whatever kind of network of care that they are providing the cares. If we look upon the concepts of continuity of care, well, since a citizen approaches the health system within the primary care, and then it transitions to the secondary care or the tertiary care, we need to have the professionals assessing the data or their information, no matter where they find themselves in the health systems, and that is why what we are trying to achieve with those improvements. So our main goal, I should say, that it will be to facilitate the access to users' informations. Nevertheless, we will also implement some solutions of artificial intelligence uses in order to support the clinical decisions, and we are investing on those. And we are also trying to, for instance, at this moment, we are implementing a system that permits the people to get access on their NHS app to the results of their analysis or the diagnosis means. We have several several information systems. It's a reality that it's across all the health systems. We have too much information systems for the needs that we have. We should consolidate them, and we should have them on much less systems, and that's what we are trying to do, to concentrate them on lesser systems and much more availability to the professionals and to the citizens. And we are also investing a lot on the telehealth. For that point, on that point, I will make some remarks further on. Here you can have some quite impressive numbers. We have about on Trace COVID. I would like to talk about the case of Trace COVID. It was information systems that we developed during the pandemics, and it was dedicated for the clinicals to monitor and to apply and to follow the citizens, the patients with COVID. And we had about 10 million registered users. I must remember you that we have about 10 million citizens living in our country, so you can see the magnitude of it. We have more than 120 million tasks created. When we are talking about tasks created, were clinical acts of nurses or physicians regarding the health monitorization of any patients. We have achieved about 18 million surveillance acts. Well, the numbers can speak for themselves. Then you will have the S-Clinic and S-Clinic either on the hospital care and either on the primary care. S-Clinic is our main health system implemented within the system. And I would also like you to pay attention for the PAM. It's the medical prescription application. So today in our country, any physician can prescribe the medication within its app or in its working post, and the patient will get it on its mobile phone and will go to the pharmacy and will get it. On these days we have about 350,000 million prescription recipes prescribed, and the 1 billion and almost 500,000 million medicine packages dispensed. Regarding the citizen, which is a point that I think that must be of high interest for your institutions. Well, of course, we are working on increasing health gains to facilitate access, to create and increase equal access, and to improve citizens' experience. How will we do that? We will do it on an omni-channel mode. An omni-channel mode, our SNS 24 in Portuguese or NHS 24 in English, is multi-platform. It's a platform that has 4 channels for the citizens to approach our national health service. You have the portal. It's a portal where you have your authentication area, and you can access to several services, since consulting your data information, your administrative information, your recipes, your usual recipes. You can schedule a consultation. And then what we have on the app is the same replied environment to give you the same experience, but through the app, and you can have all of those services. For instance, we had the COVID certificates in it, and we had I don't recall the number, but I think about 55 million access or the downloads of certificates, and well, we have about 7.5 downloads of the app. So we had in this pandemics and since to 21 about 75% of the population downloading the NHS app, and now our goal is to maintain that utilization by increasing it with added value services for the citizen. And then you have the one telephone channel. It's the same services, but via or through the telephone line. There you will find a more personalized attendance, but you will find the same services that you have on the others. And then we will have another via, which is the counter, which is a physical counter that we installed within the municipalities in a partnership with the municipalities, and that counter allows us to implement general digital transition policies, because the info excluded persons, they can access that counter, and there they will find the same services. If they don't have the equipment, the municipality will supply a room where they can access and have a teleconsultation, where they can access the renovation of their prescription with their general physicians through telehealth. And if they don't know how to manipulate the technology, but they have the technology, that they can also use that room within the municipalities, and there is an employee there from the municipality that is capacitated by us and has a special credential for that matter. We are also doing it. We have already done it in all the prisons within the country also. We are doing it also in the social sectors within the long-term care institution, and also in the elder houses in the establishments, in the social establishments for elder people. So within the telehealth, we are also increasing our services within the telescreening, telemonitoring, and telehealth itself. Our goal is to guarantee that people have equal access to health. For instance, in the northeast Portugal, we have, or within the southeast Portugal, we have large zones of low density, and where we have a difficulty to have all the specialities of all the medical specialities. And one way to overcome those challenges is to recur to telehealth, and from that point get them the access for rare specialities or very high developed specialities, and in the first phase, and then getting the patients to the big centers in the big cities, where we can attend them in a more developed, on a more profound way. I have already explained the counter. Here you have about 7.6 million downloads since 2021. In the authenticated area of the portal, you will find also about 1 million registered citizens, about 70,000 daily accesses, and one interesting point is about 70,100 scheduled appointments. Regarding our NHS 24, you will find out that we have 35 million accesses. Regarding the health data, well, we looked at the data as a resource for getting better health, a resource for research and development, a resource for improving our management, and a resource for making a better use of data. We are building a data lake where we want to gather all the information that we have within the health system according with one origin of truth, and we aim to get the same data whatever the source we look at it, in spite of what we have today. When you look at the information from one system or from or in another moment, they will always vary according with that moment and that perspective. So we want to have one origin and one deposit for it all. It's aligned with the European Health Data Space, and we hope that it can be also an axis for integration regarding the European excellence networks of care. And well, as I told you, we are investing over that data. We are investing in solutions of artificial intelligence to get a better use of it. And with the telemonitorization, such as obstructive pulmonary disease, we want to avoid the hospital bed uses, and to improve the quality of life for people. And I would say that well, in those matters, I think there's lots in common with there's lots in those matters of more proximity and more remote access to care and more access to research data. I find that it will be very usable and interesting for the quality of life, also for the patients with musculoskeletal disease and rheumatic diseases, because first of all, these are, as you can see, we have lots of tools that permits the patient to access to care, the patient access to care in a remote way. And as we know, there's those diseases, they are one of those that the patients report a very decreased level of quality of life. So whatever we can do to improve the access to health without the effort of directing to the healthcare, it will be, I believe, in a big help for them. Another point is that the data that we are collecting, we are collecting data since we started building health systems. However, as everybody knows, data is not knowledge. We have to have the capability of processing it, of researching over it, and then translate it to knowledge. And with the tools that we are creating for that matter, we believe that we will be of good health, of good help for the research and investigation, and hoping to have solutions to overcome some of the burden of that disease. Within the health data, well, you can see we have either on clinical, either on the management of the system. We have several solutions. One last word for the semantic catalogs. We are working on the clinical terminologies. We will have an international event of SNOMED here in the end of this month. It's a matter that it's unavoidable if we want to have big quantities of usable data that are relevant at the European scale, and especially on rare diseases where clusters such as ours of 10 million citizens are not relevant for that matter. So we are working on it in order to be a part of bigger clusters of information. Regarding our registers, our national registers for citizens, for beneficiaries of the health systems and of providers, we are getting it better, and it's what we are doing in a small presentation. I hope that it was small, and you must excuse me on such a short notice to prepare this, but I wanted for you to have a brief but concrete idea of what we are doing. And if you have any questions, I will be glad to answer. Thank you.
If you will stay with us, we will make the questions at the end. If you are on hurry,
I will stay with you.
okay, thank you. I would like to call Margarida Oliveira on the step. Ms. Oliveira is the coordinator of the working group for proximity in dispensing of medicines in PART. The step is yours. Thank you.
Hello, good afternoon. Thank you so much for having me. Thank you for the invitation. I like to welcome in Lisbon and hope you have a great time wherever the weather is not so good as usual. Just a remark, I'm not the coordinator of the proximity group. I'm one of the national agencies that participate on that group. I'm also at Infarmed, just beginning by telling you what is Infarmed. Infarmed is the National Medicines Authority, like the EMEA now in Amsterdam, and we are responsible for the evaluation, authorization, regulation of medicinal. Sorry, I'm sorry. For medicinal products and also for health products like medical device and cosmetics. And these include, in our country, in Portugal, the complete medicine life cycle, including the health technology assessment on the reimbursed activities. And I know that this presentation is not really about our partnership with the patient association theme is about the proximity of medicinal products, but I would like to share with you, because I'm the Infarmed contact point for this project. We have from several years now a project that's named Projeto Incluir, that means to include a project that wants to structure the relationship between Infarmed within these activities and the representatives from the patient associations. And we want to have this increased proximity with patients through, in this specific case, through the patient association, and then have a relationship a win-win relationship that could give us some information that we need and some feedback that we need, and also to provide to the patients through the patient association some inputs on our area also. And then we also have the opportunity to take the feedback and experience from the patient association in the HTA health technology assessment participation. This is I know that I see your project, and then I will see where is Infarmed in the scale, but unfortunately it was not there. But we have this pilot from some years ago, and of course with this pandemic we have to have another goals within the health, public health to do. But we want to continue with this HTA participation, the patient patients' participation on the decision for reimbursement of technologies, health technologies, and also to evolve our project in order to have another process within the environment. So we have this project with three different steps. That is, one step is to inform, to have the empowerment of the patients, and then have this engagement and consultation. And at this point, we have these three different goals. We have health literacy promotion, some informative sessions, workshops, conference, and safety quality alerts, training sessions, and in the part of the engagement and consultation, we have patients' associations as member of our consultative council. And then we have also dedicated meetings and information requests and help, asking for help and inputs on the health technology and decision for reimbursement for new medicines. And then we have COVID. And it was difficult for all of us. I'm making a disclaimer. I also know I also have rheumatoid arthritis. And therefore, when it appears, and I take some biological medicinal products also, so we don't know what to do and what is the input or the impact of our medication, because everyone tells us, oh, this is an immune deficiency. You take medicines to have less immunity, so we cannot be outside. And it was not so easy, because even if you could go outside, even take your dog, you have some afraid that somehow you can have more chance to have the illness than other people. Okay, so at least it was our feeling here. But at the Incluir project, we could not proceed as we expect with the normal activities, namely the health technology assessment. I am assessor on the health technology assessment, therefore this is my not my best area, but my dearest area. So it was not so easy to proceed with that. But we make some specific involvements and specific information to patients and population in general, but to patients during the pandemic, in the start of the pandemic. And these are some examples of information that we provided. For instance, information on the mask, the type of the mask, information on the acquisition of medicinal products by the internet, but oh, this product is very good and you can take it, and some people can purchase, made acquisition by the internet, and we make this information also with the information of adverse effects of medicinal products. And it take us also to the proximity access to self-administered hospital medicines. Just because the title of my presentation is also about biological medicines for rheumatic disease, I will take this short outside of the presentation, because in Portugal we have a specific regular environment to rheumatology and dermatology, specific dermatology and rheumatology pathology like rheumatoid arthritis, axial spondylitis, psoriatic arthritis, polyarticular juvenile idiopathic arthritis, and plaque psoriasis. This is the five specific pathologies, and this legal context is different from the access to the other medicinal products, but because a prescription doctor in his private site can prescribe these medicines. He can prescribe or she can prescribe, but the only way to have it without costs to the patient is go to the pharmacy of the hospital. Even if you don't have a consultation in that hospital, you go to the pharmacy with the prescription, and then you receive the medicinal product without costs to to the patient. The costs are supported by our national healthcare system, and that include the biological TNF inhibitors and also these not biological, but these new baricitinib, fingolimab, you know, also these. Yes, JAK inhibitors, yes. You know this medicine as well as I know. So, what we have mainly in Portugal before the pandemics, you have the prescription, and then you have a medical appointment, you have the prescription, and then you have to go to the hospital and have a pharmacist appointment with because only the pharmacist can give you at the hospital pharmacy. Is not the street pharmacy, it's the hospital, within the hospital pharmacy, and then you can take your medicine back to home, to self-administrated medicines. These apply for rheumatology and dermatology, for those pathologies that I told you. These apply, but of course these apply to other hospital self-administered medicines, oncology, bowel disease, other pathologies you may have, and this applies. And before the pandemics, we have already some proximity pilot projects, because the pharmacies, you go to the hospital when you have, in the main case, you have an appointment and then you go to the hospital. And in Portugal, and maybe in 6 months or 4 months, you have another appointment and you have to go there again. And maybe in the middle of that time, you go there to make some analysis or some exam and you go to the hospital. And in Portugal, usually these medicines are given for 1 month period. So every month you have to go to the hospital. And then the pharmacists and some hospitals notice that some patients do not go to the hospital to take their medicine because they cannot go because they don't have money to pay the transport, because they don't have way to transport themselves every month to go there. So they are specifically to have their medication, not to have consultation or other medical exams. And then at that point, some hospitals through the country, in the north, in the center, in the south, some hospitals have these programs that some people can benefit from. These they are not structured pilots, but have some indications to have. They speak with the pharmacies and the pharmacy. Oh, okay, I will give you near to your house in the pharmacy, street pharmacy, somehow give the medicine. Even also before the pandemic, we have this trying the proximity deliver to some specific medication on IHV medication, and these are 2 different projects, and then we try to know the differences with these products, the differences between having the product given in the hospital or in the pharmacy, and if it is different health outcomes, different if it is in the hospital or it is in the pharmacy, and we realize that it is not any different on that. But we know that almost the persons that are going to the hospital to have their medicine are people with chronic disease, immunodepressed people, and you have to stay at home. And therefore you should not, we try, I think that all over the countries, because for one end all the hospitals are overweight with COVID illness, COVID people, and also because you want to remove people from hospital. And then we have the first decree deliberation of our health minister that decide that starting in April 2020, all the patients should have the opportunity to have their medicines at home or in the pharmacy and the street pharmacy near at home, or in the other hospital near at home. It's home, and then this is the stay-at-home phase, and then Until now, we have this deliberation in place, but we have to evolve somehow in this. This is not should not be an exception, but should be the rule. And therefore, in July, we have a dedicated working group to recommend rules and procedure to have the proximity delivery for all the self-administered hospital medicines to be applied to all national health system hospitals. Because passing the first phase of COVID, we know that some hospitals maintain these proximity proceedings, others cannot maintain because it costs to the hospital, and we cannot have some patients that could have the product at home and others could not have because the hospital is not the same, so it's not always so easy to understand. So what we have at pandemic was the delivery on the pharmacy. Of course, is always possible to have it in the hospital pharmacy, in the street pharmacy, and then you can have it at home. And we do another thing that some regional systems can take herself as a take care person, and I can go to the hospital to take the medicines to my neighbor. I can do that. It was possible at that time. So we have now this working group recommendation. We have the first report in October, almost 2 years ago, and then we have extensive public consultation and the final project last year. And as you know, we have this was the before, and this is the future, and the future will be to have several possibilities in proximity delivery, and it will be, of course, in place of in the pharmacy, in the hospital pharmacy, or the central hospital pharmacy, or the hospital pharmacy nearest the home of the patient. Also in the primary care facilities, on the street pharmacy, and of course at the patient home. We have now in place the proceedings that legally will bind the hospitals to implant these differences. Of course, we have from 2 years now different hospitals that maintaining from COVID crisis, first crisis, the proximity access, and the others that could not do that. And with this legal framework, we will be able to have sure that every every patient in the country can have equal access to this proximity possibility. And I think that it was, oh, yes.
Thank you, Ms. Oliveira. Sorry. Now we will have the last part of this session, which is a roundtable discussion with Elsa Mateus, Athanasia Papa, and Ms. Oliveira. So I would like to invite Athanasia first to make her presentation. Okay, sorry. First, we will have some questions regarding the digital and citizen-focused healthcare that was by Mr. Posiano, by Dr. Posiano Oliveira. If you have any questions for that part, and then we will continue.
Thank you. It's not quite really a question at the moment. It's more an additional comment, an additional remark, which I believe it's important for other patient organizations, because it's one of the things that should be highlighted is that the SPMS has also involved patient organizations in trying to see. We have several meetings and trying to design a better approach to the citizen. So I think this is something that should be highlighted because it's a good practice, and it was shown already that we were able to develop this kind of digital approach to citizens and also have a very good way of going around inflow exclusion, for instance. That is something that we usually discuss, how would citizens that are that don't have internet or mobile apps or laptops or whatever, and it was a good solution that was it's being developed and still enlarged, I believe. So I think these are a very good aspects to have in mind, and I would like to acknowledge that and to appreciate the work that has been done, because seriously, listening to patients and to patient organizations can be very helpful, and we can help building things better for the future. So this is one of the things, and I think it's a great challenge to address interoperability at the national level at once, and then you probably have to deal with the European level, because when we talk about the European health data space, we need to align our structures in terms of interoperability, and then to also make sure that they will connect and be interoperable. They will have interoperability with the European level, because you know that we travel a lot, and we never know when we need to have access to our information. And I think this is also a good challenge. And I could not stop noticing that we around, for instance, on self-monitoring tools, only 20%, perhaps, because it's something new, of users. So I think we also need now on the next step to see how patient organizations can work together with the providers, so to enable and to disseminate and to empower people to engage in self-monitoring and using these tools. So that any suggestion would be welcome. Thank you.
You can answer from there.
Well, I will just I will just make 2 or 3 remarks over those issues. First of all, to thank you for your kind words. Actually, our governance plan for this resilience and recovery plan is a very inclusive one, but of course that we take the kind words and we make our efforts to include panels such as the patients associations, where you know that we have several meetings, but not also with patients, but also with the professionals, with their bars, with their associations. We have several reunions. And we speak about what we are doing, the ways that we are going through, and what we are aiming is to get the acceptance of the users. And the main users are the patients or the professionals, so the systems are for them. But then there are needs for the whole system, and we have a third panel where we are gathering distinguished personalities of our health sector and the history, in order to get also their acceptance and their validation for what we are doing. Regarding what you said about self-monitoring, I totally agreed with you, and that's one of the reasons why we are involving the patients' associations. The first step for fostering the use of telehealth is to create a fostering environment for itself. And you will not have it if the solutions are not developed for the users, for the end users. And well, for instance, there is one of the aspects that it's not on our presentation, but is we have noticed in some surveys that we have made for that effect, or that we have studied for that effect, is that people with chronic diseases, only 3% of them use self-monitoring or telehealth tools, and that's probably where the most value. There is problem in the place where, I'm sorry for the of the expressions, the people where the value that we can add with those processes is probably, most of it is probably there. In what regards to interoperability, well, we know it's it's a cross-border problem, but we are solving it. For instance, when I talked about reducing the number of information systems for the same solutions, well, the first way to get interoperability is to have more common information systems for the majority of the functionalities that we are trying to get from them. The second is language, and that's why I talked about semantics and clinical terminology, which has very high importance, which are from very high importance within the health sector, in any sector. But well, in this one, there is a very particular vocabulary, and the need for increase the awareness of the importance of semantics is of high priority. We are hosting from SNOMED City in the end of this month an international event, and we are also taking the opportunity to have some local workshops with them in order to raise awareness and the knowledge from those clinical catalogs. Regarding the European interoperability, well, we are not only committed with it, as we are in the leadership of one or two working parties, working groups for within the European Health Data Space development framework. And for instance, in the COVID certificates that are used in all the European Union, they were developed during our presidency and became the solution for mobility all over Europe. And we have in that matter, we have a very forwarded position within the European Union, and despite that, we still pay attention. We are still committed with the principles, with the ethical principles of using technology, which is something that for us is a point of very high importance. So I think that all of the aspects that you are worried about, they are also a part of our preoccupations. And in what regards to the paper, the role of the patients' associations, well, it's not only our will, but it's also a demand from our national health basis law. And it's also, well, in these days we have the government has approved a new executive board for the whole national health system, and it has 5 main tasks, and one of their main tasks is to promote the participation of the patients within the governance of the system. It's something that for me, it's the only way to overcome the challenge that is brought to us by the people's expectations.
It's our next session about this.
Okay, I will leave it for that.
Yeah. Thank you very much, Dr. Oliveira. Yeah, yeah. Of course.
First and foremost, impressive. It's really stunning what you have set up with your group. And if you talk about panels that you have with patient advocacy groups, with clinicians, I assume, with clinical societies, if I understood you correctly, with what is called Infarmed, yeah.
Yes, it's the Medicines National Authority.
So this is excellent, and I guess when it comes to telemedicine, you need some patience, because I have watched the process in the US over ages, and it's still not there. So, anyways, one quick question regarding registers: are your national registered? Are they forced to provide you with the data, or can they feed data if they want? You mentioned 3 registers.
We have 3 registers. The providers, well, it's the list of the providers, of the clinicals, the public or the private or social providers. You have the citizens register, and then you have the professional register. I believe that you are talking about the professional. Well, the professional, we have to, this is one of the registers that we are in this moment developing. It's a law of 2014. It's still not accomplished, and now that we are working on it, we have been working on it for for a long time now. But now that we are developing it, the law is no longer according with today's reality, so it will be a pathway that we will have to get through, and well, from my words, I believe that we have come to the same conclusion, but we will get there.
Okay.
We have already one bar association available to do it, so it's the beginning.
Last one, because we have to continue.
Okay, it's very brief. In Galicia, we have a health system, and we have a similar program that this is like, it's called Sergas Mobile. It's like for Galicia, you know it.
Yes.
And we have the prescriptions in the platform, and I would like to make them available abroad. So if we could, now I'm here.
To Minho, to Viana do Castelo, for instance, across
if I
the
need
frontier.
my prescriptions here, while I'm here, I could just go to a pharmacy here and show this, and to be compatible, it would be a dream, because it's not even possible in Spain, but it would be like a pathway to work within countries in the way of the interoperability that you were mentioned, and I think it would be an idea to.
Well, we already have it. Well, first of all, you will excuse me the special compliment, because Galicia is the neighbor region of the North Portuguese northern region, health region, that I was a part of the administration during 10 years, and I actually celebrated a protocol for cooperation with Galicia, and well, it's well known from the northern region citizens. The fact is that we have been. I forgot to say that to you, but we have already implemented an e-prescription and e-dispensation and cross-border access to health to the health summary, patient summary within the country. At this moment, we have already the interoperability with 4 countries, and Spain will get into it. I believe this month. They are in tests, and maybe after that we will have that. We are working on the tests with Spain in a European level. All of our hospitals are already connected to. Our public hospitals are all already connected in order to share the electronic patient summary. It's a small record. It's a summary. It's a record summary that where they will have if they have any kind of need within the country that they are in Europe at this moment, only on those that are connected already, they will have the access, and they will not only have the access for the patient summary, but also to the e-dispensation and e-prescription as they would have the right within our country. And if you can see, this is only the concretization of the European cross-border directive.
Why is it so difficult? Europe is doing everything to look very difficult when regarding the health of the public, and especially when, for example, we have a lot of students that are going all around Europe to study, and we're struggling to help them to take their medicines. And this is very frustrating for all of the patients, because we cannot travel to Europe due to our condition and stay somewhere else. And I don't know why Europe, it doesn't fix this. We have the European, how you call it, when you need a special treatment or a special
it's
operation.
Cross-border rights.
Yeah, the cross-border rights. Why we don't use this? And about the chronic patients and the medicines.
Actually, according with the European law, you have the right for it. What you still don't have is the practical barriers, the practical blocks for it. You don't have it so easily.
The mechanism.
The mechanisms, exactly.
Yes, but European Union has all of the countries, and the ministries of the countries has to make the mechanism to work. We are on 2022, and we are all have one phone, and we are doing everything from this phone. I don't believe that the ministries of all countries, of European countries, cannot do this.
Well, of course, but it's so difficult because it's a titanic task. It's a huge.
It's so difficult
it's not
because
so simple
somebody
to do it.
doesn't want to do it.
I only that we have today. We look at the cross-border rights in what patient mobility regards, and we look at it at an achieved right. But the truth is, it was only in 2011 that we came all together around the conclusion that it should be implemented in all countries, and for that point on, we created the first base in order to create the electronical facilities, and from that point on. So I think, well, Europe is a unique project within the civilized world. I believe it's the first time in history that people civilizations are voluntary, getting together around one idea of a common standard of life, but voluntary. We had several experiences, especially in Europe, during all the centuries, but not one of them was voluntary. So I think that we will have to have a little patience and do not give up of
We
that
are patient.
dream.
We have patience.
We know. Exactly.
Thank you very much.
You're welcome.
Thank you. So I would like to invite Athanasia, Elsa, and Margarita Oliveira to do our next presentation, which is contemporary experiences from Portugal, Cyprus, and Greece. And it's going to be a roundtable discussion.
Okay. Thank you very much. I'm very happy that for my participant here in Agora conference. I know that all we are tired, but this time is the time of the patients, the voice of the patient. And you see color, nice color. So, I'm going to present you what happened in Greece as regard the medication delivery. Here, okay. You can see this. And now, okay, the introduction of a new medicine in the Greek market consists of the following steps. Granting marketing authorization is the first one. In case of centralized procedure, the national phase lasts 2 months. Objection price is the second step. It is worth mentioning here that the base price in Greece is the X factor and is determined by the average of the 2 different lowest prices in Eurozone countries. This step usually lasts for 5 to 7 months. The third step is the Health Technology Assessment, HTA. The HTA committee is responsible available the clinical evidence and the cost-effectiveness results. Most of the products need to fulfill a certain criterion in order to proceed with HTA submission, namely the external criterion. According to this, products should be reimbursed in 5 out of the basket of 11 countries. Then, as long as the HTA committee gives a positive recommendation, the negotiation committee will assess the budget impact of the project. Finally, the project will be included to the prescription system. This process only lasts 10 days. Based on our experience, the overall process can last approximately about 18 months, which mainly due to the significant delays between the HTA and the negotiation phase for bureaucratic reasons. Okay, this is the per year now. Okay. And here you can see the time to available of project, which is the time between marketing authorization and availability to patient. In approximately, you can see 550 days in 2022. As you can see, this time had been a statement here. You can see Greece. There. 447 days in 2020 based on IQVIA data. For instance, the respective time in Portugal, there, okay, has been a statement at 641 days. We don't have a number for Cyprus. I don't know why you can...
Yeah,
yes,
Cyprus is not giving any data, any details about this. And we have talked to them and they said that this is ministry thing that they don't want to share.
Yes.
But we are far away from there because we are a small island. So we... to give you an idea, first, Greece has to have the medicine, and then we will have it. Then we will go to the process, because we are a small island, a small country, and we have some other barriers also.
Mm-hmm. Okay. So, go to see what happened here. Pharmaceutical products are available to patients through 3 key distribution channels. You can see public pharmacy, namely AOP pharmacy, private pharmacy and hospitals, either private or public. We also have a courier service. Okay, but you will see later why now here courier is red. High-cost medicines are available through AOP pharmacy and administration at hospital. like infliximab, or like in addition to the main distribution channel, there are also named patient program. In this case, products are imported through IFET, the public wholesaler. Delivery by courier has no legal framework. This is why it's red. Okay, we don't have a legal framework until now. The procedure for named patient program SIP, as we call them, is obviously rule government. The process starts from physicians who are responsible for making the request for such a program based on the medical need and previous treatment of patients, and should also provide available clinical proofs and document benefit for the patients. Then the SIP administration, EOP, the larger healthcare payer in Greece, will forward the request to the HTA committee or National Organization for Medicine. The committee will assign the request to the 3 medical advisors based on the diseases of the patients. In the opinion of the advisor in positive, it will be forwarded to the board of EOP to issue the official approval. If not, then the request will go back to the SIP administrator. Similar to other European countries, patient support programs are used by pharmaceutical companies to support patients. Patient support programs can involve various services, from informative sessions to delivery of pharmaceutical products. Physicians are responsible for informing patients, while health authorities are not involved at any point. Although that since 2015 there is delivery of drugs to the patient by courier companies. It is significant to mention that there is no legal framework for that in Greece. Okay. It is clear to mention that 35, here in Greece, 43, of a new medicines are available through named patient programs in Greece according to IQVIA data of 2020. While nearly half of the new projects, 43, are not available at all. You can see it here. And Portugal is 47. Okay. In conclusion, I say that overall the key issues that we are constantly facing is the availability, the time, and the lack of legal framework. In terms of the availability, as already mentioned, a great number of projects is not available. This is mainly due to low price, the fact the prices increase in prohibiting, and the high impact of clawbacks and rebates. In terms of time to availability, as already described, it takes almost 1 year and a half for a new product to be launched in the market. Unfortunately, the delays are only increasing, and there are no penalties for any of the involved parties who are causing them. Last but not least, the lack of legal framework for patient support programs creates significant issues, as there is no control from health authorities, while it usually remains unclear how personal data are handled. We, Hellenic League Against Rheumatism, have sent a letter to the Ministry of Health and to the private companies asking to inform us the legal status. We have no reply until now. Thank you very much. I don't know about you if you have delivery in your country, but we have, and as you see, we don't have a frame legal.
Okay, first of all, in Cyprus, as you said, as we said before, we don't have any data of how many days or how many years is to be available in our country a new medicine. We have the national authority that is assessing any application, and that is approximately around 5 months is taking them to assess it, the application. And then it depends from when the medicine and who is gonna make the application, because sometimes some clinicians, they are asking for a medicine, so we have the other way around to ask for a medicine, and then the health system or the ministry is going to look for that medicine and to ask who is gonna bring that medicine, so they will go to the company. Or if the company by itself wants to import the medicine, then it's going from the normal way. And it takes around 4 to 5 months to assess the application. And after that, it takes around 3 months to bring the medicine. Except if it's something very urgent, that they will make ad hoc committee in order to approve earlier the medicine. In addition to that, we have in the system, we have a new health system in Cyprus. We didn't have health system until 2019. 2020, with the COVID, we have also a new health system, and that make us with biological and biosimilars not to be in the system. Because it was very difficult to put in the system at the beginning this big amount of money and big amount of difficult patients to be in the system. So for almost 1.5 years, we didn't have the biological treatments through the system. We have them only through Ministry of Health as an exception. So a patient, an RMD patient, has to go to the physician, and then the physician should make an application for the treatment. And we used to have also 2 types. One, it was through a protocol. So if the patient was need a biological that it's on a protocol, the physician will ask for the medicine with the profile of the patient, and in about 1 week the patient was gonna have the biological treatment. If the treatment wasn't on the protocol, then the patient has to wait around 1.5 months to pass from ad hoc committee to take all the details about the patient, and then he will get the prescription and the medicine, the biological treatment. This caused a lot of confusion between patients and between physicians. After they put the biological treatments in the system, and now we have biological treatment in the system, again we have two types of patients. We have the patients that are taking their medicine through the system with the normal protocols that we used to have, but we have the namely approvals that are going through the Ministry of Health. Because until now, they faced an issue to put them also in the system. And when it comes to then delivery of the medicine, we only have biological medicines through the hospitals, so we don't have then delivery to the neighborhood pharmacies. We are trying and we are demanding to have them through the neighborhood pharmacies. This is gonna be easier for the patients. And we also have the issue that the pharmacies that they are available, our biological treatments, are only the governmental hospitals. Because in the system we have private hospitals also and governmental hospitals, but biological treatments are only through the governmental hospital. We faced issues either with private hospitals or with private pharmacies, the neighborhood pharmacies, because they are telling that they cannot afford the amount of money that they have to spend until the system reimburses them. So it's a very big issue because we know that a system is reimbursing late the different service providers. So we have this issue and we are trying to find solutions, and we are proposing solutions to them, and we hope so that on some time, maybe in 1 or 2 years, we will resolve this. Yeah.
I don't know if you want me to just make a comparison or making an update on the status on the Portuguese access to medicines. So I think I don't saw it really from here, but I think that the graphic, the figure you show, it was the time between the marketing authorization given by the
I don't know how it sends it. Which
by the European agency, and then the time that it takes to have
Could you change it, please, to see the graphic?
To have it reimbursed in the national system.
For with the days.
The first one, yeah.
Ναι, πρέπει να πάμε σε αυτό. This one.
No, the other one.
Until they find them, I would like to
Here.
say to add also that in
Here.
Cyprus we
There is,
don't have all,
this number is
we don't
for
have all the biological
2020.
treatments
Yes,
because
but
we are a very
now
small island.
Yes, but
IQVIA.
this is between. Sorry.
I was saying that in Cyprus we don't have all the biological treatments because we are a very small island, and the pharmaceutical companies, they don't want to put some medicines because due to the cost, we are a small island, so we'll need a cheapest medicine, so they don't want to raise down the cost of the medicine. And as we know, the pricing in Europe is going between the cheapest and the higher. So
Yes.
they don't want to, some medicines they don't want to bring them in small countries. Also some biosimilars, yes.
But biosimilars, they're supposed to be cheaper than biologics.
Yes, of course, but this is the market. Yeah. Yeah.
This figure, indeed, it takes the time between the marketing authorization given for these biologic products by the European agency and the time that each country and the decision to have the reimbursement to the national system. It depends, of course, it's a national decision that depends on the budget of the country. So it's different for Portugal probably to have some product financed, or Germany or the United Kingdom or another country. So, and this means that Greece, if you see Germany and Denmark and Netherlands, Sweden, Austria, they have a different, I'm speaking from Portugal, they have a different power to have the medicinal product, and they can pay more for that product. So the company, as we see it, the company have these tires different tires on the countries, and they will not submit the application to us to assess. So when you see from Greece that they can take 500 days, okay, but that may mean that the company just make the application 2 months before. That, okay, it's not, at least in Portugal, the legal framework depends on the company make the application for have the product reimbursed. And sometimes, of course, it's not as the Cyprus situation, but sometimes we are a small country. They have to have. They have to have. That's okay.
I tried to find.
Yeah, they have to have the package leaflet in Portuguese, the outside carton in Portuguese in the national language, and sometimes they will not go to Portugal to have the medicinal product in Portugal, or they decide to not ask for reimbursement. Whatever it is, we have this special authorization procedure that sometimes before the marketing authorization and then from the marketing authorization until the reimbursed conditions at national public hospitals, the patient can have access to the product if they have no other alternatives, medical alternatives for the specific case, even if the company will not submit the application in Portugal, of course. And the other thing is when we see different, because I think it's important, you see this figure and you see, oh, Romania or Poland have, this is not really the real picture, because the real and old picture, because sometimes we have to negotiate within our national budget, and we can take time, and sometimes we ask for help from the advocates, from the patients, because if I have a company that say to me, okay, I can have your product, but it costs something, we can give the example of the C hepatitis. I don't know if you remember some years ago, a new medicine, and our budget only allows us to treat a specific number of patients. And then our effort, the patient advocates effort, can give us the power to negotiate with the company to have all the patients in Portugal to be treated, to have that treatment. And this is very important to the patient association, because the payer, the Infarmed of all the countries cannot alone. It may do not authorize the reimbursed or retrain the reimbursement until we give the special name authorization and the patients have access to the product. But we cannot. Sometimes we don't have the enough budget, the national enough budget to treat all the patients that need that medicinal product, and we need to have the product with minor cost. And sometimes all the times, we have to have the patients from our side, because probably if we can have the patients on our side to say to the company, because always the company said we have to go to have the medicinal products to the patients, but we cannot afford, if the country cannot afford that treatment and the other one and the other one and the others, it is needed to have lower costs to have the products in the country. And therefore, these differences sometimes, of course, I'm from the national authority, and you can always say, oh, of course, you are seeing your side, of course. But I know that sometimes we invest several amount of time trying to have a product with lower costs in order to have budget enough to have other products on the market. Okay. So in Portugal we have also the problem with the higher prices, and also the problem with lower prices, because sometimes the company, we have these international references on the costs of the medicinal product. And if Greece have one cost, my product package cost has to be some percentage points below the price from France. So the company and the price from Greece should be lower than mine in Portugal. So the company will not ask first for mine because Greece will have to have a price lower. So it's not so easy to have all the country or to the product, and somehow the low cost products will not come to Portugal because they are so cheap.
Yes, but in Greece, all the pharmacy company all the time complaining about the rebate and clawback, and this is a big problem. And all the time the patients say HTA must work good and hurry. Why you delay?
We don't have HTA.
I know. We
Yet.
haven't
They are
now
trying, but
4 years, and we didn't have, and it's a big problem because now for 2 years it didn't work. They work for something else, and we have a problem. But in Greece we have everything. Okay.
Mm-hmm.
We can take everything for everywhere. If we have insurance or not, we have insurance. If someone is poor, the pharmacy
Portugal.
take. Okay, everything.
Mikael wanted to.
Yeah, the courier that you spoke about delivers all kind of the medicines, even
Yes.
even biological that needs.
Until now, biological, biosimilar. It's for the company, the pharmacy company has a support patient program.
Okay.
Okay, and from there go the pharmacy to the patient.
Okay. And you said that you don't have biosimilars in Cyprus.
No, I said we have biosimilars.
Oh, okay. Oh.
I
Because they are cheaper.
Yes.
So the law in Cyprus, when you have the biosimilars, if you have a patient that is on
Biological.
steady and remission and really
We don't have switch.
you don't have switch.
No, we don't accept switch. Switching is not in the
For now.
process on our system. Yes, but a new patient, a new
Naive patient.
a naive patient is gonna take the biosimilar.
And not the biological.
Sorry.
Yeah.
Yes, the biosimilar. If it's
Yeah,
a
yeah.
biosimilar in the protocol, yes, it's gonna take the biosimilar.
Elsa,
But we don't
in-
have switching.
How is in Portugal, Elsa? How is in Portugal?
Yeah.
Sorry.
Yes. No. It's okay. Yes, because we in Portugal we may have this some situation to switch, but the question is, it's fresh news. I think this week the European agency have a paper that confirm the interchangeability between biosimilars, different biosimilars for the same active substance. So they make a study and they have this paper. I can therefore share with Elsa. Elsa will share with you this paper that can allow member states to make mandatory this interchangeability, the switch between biosimilars and other products.
Between a patient that it's in remission and it has a biological.
By the end of today, if you can confirm that, if the EMA could confirm that the therapeutic and safety profile of the biosimilar is the same as we have with no biologic generics. For no biologic generics, you can have other ramipril, you can have from generic of the brand ramipril, for instance. For biosimilars, in the moment that the European agency states that it's the same, of course you may not agree with them, but this is a statement from it's not a statement from Portugal. For the policy in Portugal for the politics in Portugal or for the health policy in Portugal. It's a statement for the assessors from the European agency saying that it's okay to switch between biosimilars because it is the same. The amount of active, I'm pharmacist, the amount of active substance that you receive in your body is the same. I will tell you, I have sometimes I take an etanercept. And the only problem I have with etanercept biosimilar, it was the method of administration. I don't have strength enough in my hand, so I have to make it force, and I don't have strength enough because I don't have any button to press in this. So this is the problem. Yeah, this is the problem. It's not the medicinal product by itself, but the delivery system. Yeah, it's because in my problem I cannot do that. I can do that, but I cannot do that. It not be displaying the medicinal product. So this is the problem in my personal experience. So by the end of the day, if you have the same amount of active substance, the same amount of the compound that is in your blood that will make the same effect, as we know now for the generics, the chemical generics, it will be the same. I'm not a medical or a pharmacology assessor, but I believe that the European agency don't have this budget of political health questions, and therefore if they have a paper that said that to us, I will tend to believe it, because it is not an easy step. It's not a easy step to.
It's a very easy step once you saw the Scandinavian switch.
Sina wants to make a comment, and then Boriana.
Oh, sorry,
One lesson we learned from COVID and the vaccines made available in the European countries was that the health ministers at EU level insisted on a similar approach. And maybe it is our duty to be lobbying ministers to take similar approaches in these situations as well. Because we were faced with the COVID tragedy, if I can use that language, they all consented because they wanted a way out. Now, for patients living their lives with the condition without the proper medication is another tragedy. It is up to us to be lobbying ministers to have that kind of approach. And I think then everybody will be the winner. Thank you.
And now Boriana.
I would like to ask about biosimilars. Isn't it different from the normal generics? I think that from when you manufacture biosimilars, biologics, it differs from. So you can't be sure about the right amount, the exact right amount of ingredients that you receive when you take biosimilar or biologics. I understand that because of costs, it might be substituted. I talk about the procedure of substitution.
The switching,
the switching, but it's not the same as it is in generics.
Yes, and the generics. Sorry.
In addition, is that the biosimilar is taking the same indications of the biological without making any trials on the specific patient diagnosed. I mean, when it's making the clinical trials only on 500 people with RA, and the biologic has also AS or PSA, then biosimilar will take also for PSA and AS indications. So I think this is something EMA has to overthink about it, because it's not so clear to the patients that this medicine is gonna do the same
Yes,
work as the biological.
Yes, I
We understand the
yeah.
cost,
Yes,
and we
yeah.
understand
But it's
that
not a question only. I'm sorry, I'm very enthusiastic. No, it's not only a question of cost, because as she said, also said, you may know because it's not you do not pay for the medicine, and at least
No,
in
we are
Portugal
paying.
at least in Portugal we don't pay for the
we
medicine.
pay through our taxes.
Okay, we don't pay for the medicine, and
We
for
are paying through
But
taxes.
would
no,
you
but
allow
That's
me a
not the
comment?
issue.
No,
I think
Because
No,
we're
the
not talking
question
about the
is-
real issue
no,
here.
I
No.
think what Margarita is saying, that we patients are never aware of the real costs of the medicine. What we only, at least in Portugal, I know because I look when I go and get it, they provide me a receipt and I need to sign it, and because I want to know, I look and see the price. But the price that is there is not necessarily the same price that the state pays for the medicine. There's a lot of things involved.
And
So
several
that's one
times the biosimilar the brand medicine takes the price lower than the biosimilar.
We don't want biosimilars to disappear.
Yeah.
Okay, because we know that is giving access to more people to the treatment. Okay, the thing that we doubt is the switching. But I would like to give the microphone.
Sorry, tomorrow I briefly comment on that, maybe in my short presentation, but just the difference. A biosimilar is not a generic. Unfortunately, there's a huge knowledge gap, but not only around patients, but also across physicians, in particular now in the US, as we see. So a generic, in short, a generic is a small molecule. You know the ingredients, the excipients. You can just take one diclofenac and produce the next one because you can read what is in there. A biosimilar is developed from living cells, from living organisms. So each and every biologic and each and every biosimilar has variability, which changes, but it must stay within certain margins which are set up in very, very stringent regulatory processes by the EMA and by the FDA. Now, the difference in thinking that we all must understand, we are not focusing, and coming to your point of extrapolation, we are not focusing on the clinical studies anymore. What we are focusing on is that each and every biosimilar manufacturer in the world has to figure out a blueprint, because no originator company will tell you this is how we produce it.
Yeah.
You have to figure that out in very complex comparative pharmacological and non-clinical studies. And here is the focus. You have to figure out, how do I get an identical amino acid sequence? You have to figure out, how do I get similar physicochemical properties within a margin of variability that also the originator has. You have to figure out, how can I get to the same biological, and that's an important point, the same biological activity, which may be in terms of anti-TNF, the TNF neutralization, the TNF binding properties, and so forth. And once you have demonstrated that to EMA or FDA or both, they say, okay, now you are ready for the next step. Now you show us in a pharmacokinetic phase 1 study that you have the same drug concentrations in a healthy volunteer population. Once you have demonstrated that, they say, okay, now you are ready to go for a confirmatory study that demonstrates in a sensitive patient population that you will not create any surprises later on in clinical practice. But this is currently under consideration because the EMA already discusses, do we need a confirmatory clinical study? Because once a biosimilar has shown in those non-clinical studies that it's absolutely the same within the variability margins. With the same, you will never see something different because you know about the safety, you know about the efficacy, you know about the immunogenicity of the originator. So you don't have to necessarily demonstrate, until now you have to, but they want to even drive away from that. Interchangeability, they have always said, okay, this is to the discretion of each and every country. We don't talk about that. Interchangeability, again, is another issue because it is often confused with automatic substitution. It has nothing to do with automatic substitution. Interchangeability should be, by nature of the product, be there. Because every biosimilar is the same. It doesn't matter whether you take a biosimilar basically from Sandoz or one from Biogen or one from whoever, Boehringer Ingelheim. The only things that are different are, for example, the devices. So it's probably the pen that then drives the decision for a physician, plus hopefully the patient who has hopefully a word to say, I would rather take this one, not that one. Price-wise, they compete with each other. So usually they are always somewhere in the same area of spiral. But the process is a very different one. And usually we should not necessarily talk about cheaper products. They are more affordable. The development of a biosimilar is around $250 million US. So yes, it's still cheaper than the $500 to $750 million for an originator, but it's still a very complex procedure. Sorry for this long spiel, but
No,
Very
thank
good,
you.
very good.
Thank you, yes.
Yeah.
So, Elsa, do you want to?
Yes, something
Where can you sit?
to conclude, I think, because I think we probably
Yeah.
need to
We are over.
try and conclude this. I think we have a very interesting discussion. I still believe that in Portugal we have some issues, of course, like every other country. I would not say that everything is perfect, but I think that one of the main things we have achieved is to work in closer collaboration with the National Authority of Medicine. Also, as far as I understood, and I wanted to ask you, is there any other country where, from the Agora, from our members, that is involved in HTA procedures? Because now in Portugal, patient organizations and patient representatives, like Margarida presented, are also involved in the HTA procedures. They are asked to provide their input. And I think this is a very relevant area, and perhaps this could be something that Agora could explore in the future. And this is one of my remarks or comments. So I think we still have a long way to go and a lot of work to do, but I think it has been very useful to have a closer collaboration with the National Authority of Medicine. And they are getting patient organizations on board on one hand, and the other thing that we were discussing previously was about getting the possibility of getting not just on the market, but after being in the market, to get your drug delivered in a more comfortable way, I would say. So as you understood, we were also involved in patient organizations in this working group to produce some recommendations. But as usual, now we are, I think, at the stage of waiting for the legal framework for these to be implemented. And apart from the legal framework, and I think this is an issue that could be the same for all countries, are the concerns around safety of the pathway of the distribution and also regarding some privacy. So this is some aspects that are also included I believe, in the legal framework. And another one, I think it already mentioned, was about budget and costs, who will be responsible for the circuit and who will take responsibility for paying. So I think if you need some example in your country, you can ask us, and I think that the working group and all the work and discussion on how to make this circuit work, I think perhaps it could be also useful for you, for your own countries. So this is what I wanted to say. Thank you. And I feel very lucky because in Portugal we have 14 active substances available, fully reimbursed by the state for rheumatic patients. So I think it is really something. So yeah, thank you. Okay.
Yeah. Thank you. Thank you very much for this brilliant conversation. We are continuing. Mariana.
So it was a really interesting session and very good discussions and information. And we are running out of time, but be patient. Yeah, we almost had to finish at this moment, but
So it's me again.
so we
I hope
have
so you
our
didn't-
last session for the day.
Yeah.
Engagement of patient organizations in decision making, and of course Cyprus, they are very professional at that level.
We have one thing that we are professional.
Yes, not one thing, but you're really professional at this level. So we will listen to Andri Foca. She doesn't need a presentation, but she is the chair of Agora and has so many other roles. She is part of ASIF, also ULAR, UPATI, and so on and so on. So Andri will talk about engagement of patient organizations in decision making.
So
Yeah.
thank you. It's my last thing for the conference, I think. I will be fast because we are all tired. So we should have here Marios Kouloumas, who is the professor of the professors for patient advocacy. But unfortunately, he couldn't be present here, so I will make the speech. So in Cyprus, we have the Federation of Patient Organizations. The federation, these are some of the members of the federations. So the federation was established in 1986. By now, it has 33 national patient organizations. In the board, it has one representative of each member. And it has executive committee, 7 members that are voted by board. It has a scientific committee that it's a 6-member interdisciplinary advisory committee, and also has on this advisory committee has patients, has researchers, and some other scientific advisors. It has also a huge collaboration between the universities that we have in Cyprus, the medical universities. We have 3 medical universities. One, it's the governmental, and another 2 private universities. And the organization chart, it has administrative officer and patient rights officer and secretarial officer. It's a federation, it's a member of European Patient Forum, and its economical resources are through membership fees, government sponsorships, and some other sponsors. This is the logo of the federation, OSAC. in Greek. It's Ομοσπονδία Συνδέσμων Ασθενών Κύπρου. This is the Greek, the Greek name. So it's OSAC. The definition of participation. Citizens have the right to participate in the planning, implementation, and evaluation of policies related to the protection of health rights based on the following principles. This is the EU 2002 right to participate in policy making in the area of health. The fundamental patient rights. Every patient has the right to equal health care provision. The patient has the right to good quality health care. The best interest of the patient should be the main factor in choosing between various treatments and care. The patient has the inalienable right to choose. The patient is entitled to full information, and the patient has the right to be treated with dignity. Inequality and discrimination, access queues, questionable quality services, the security, these all are things that patients usually has to face in everyday life. Uncontrollable spending of money, of time, of effort, of pain. Pricing of the services, many times we have to pay for our health, and the patient dissatisfaction, which is a huge thing. This all we faced for many, many years in Cyprus, due to the lack of having a health system, as I said before, and due to the lack of being a patient, a chronic patient, that is very, very difficult. Assertion of role and participation. So, we have to make a campaign for institutionalized patient participation in health policy. And we have to do favorable conditions due to the huge problems in the health sector. Support from political parties and MPs, but mainly from the Ministry of Health. Support from the civil society, the OSAC, the Federation of Patients, as one of the most reliable institutions of the Republic of Cyprus. So to make the role of participation important and concrete in Cyprus, we have to make campaigns. So to be part of the system, to enroll us in each decision making, and to have in mind that patients have not only rights but voice also. So we faced the chance of the new health system. We took the chance of the new health system, and we raised our voice, all patients together. And in addition, we had a very good, at that time, we had a very good Minister of Health, that he was available to discuss with us and to listen us and to see how important was the patient to be participate in all decision making. The role of the patient movement. We had to create a strong monolithic organization, which means that we had to make one federation for all patients and not to have each patient organization for different diseases to fight by their own, to compete each organization with other, who is going to take more. Because the system and most of the time the economy of the health is make an organization to fight between of them, who is going to take more. But with a federation, we were one group together fighting all together. So we ask for equal access to quality health services and focus on patient needs and the patient-centered care. We make promotion of reforms in the health system and participation of patient representatives in health policy, in the development, in the implementation, in the evaluation of health services, and we show that patient education and empowerment also is very important to face all these obstacles. So we raised the Nothing for Us Without Us. It was very, very important to show to the people that we are all together. The participation of patients should not depend on the goodwill of politicians or other state officials, but should be institutionalized in the context of equal participation in the formulation of health policies. So, sorry for my Greek. It's the law about the negotiation of the government and other services in all the types of matters for patients. So the Minister of Health, Yorgos Pamboridis, said the mature stage in which the patient's movement has reached allows the state to see them as partners and not as opponents. Stella Kyriakidou, that you all know Stella Kyriakidou, she's from Cyprus and she is a supporter of the Federation, said at a time when healthcare reform is desperately needed, we are giving to the organized patient groups a voice in this conversation. The president of Patient Federation, Marios Kouloumas, said historical moment has been a request of the patients' organized bodies for many, many years. And the assistant professor of health policy, University of Peloponnesos, Kyriakos Souliotis, said in the 3 EU countries with the lowest patient participation in decision-making that concern them are Cyprus, Greece, and Italy. In 2016, the Parliament voted the law regarding the participation of the patient in each conversation is making a decision in each conversation about patient rights and the health issues. So the Federation now is represent to many things that are under health system, and some of the areas of interest and the participation are the formulation and implementation of health policy, the patient rights, establishment of observatory body, so the Federation make an observatory body for the patient rights, and each civil of Cyprus, each person can go on this body and make any complaints about what's going wrong with his situation in the health. We have the research, we have the EUBADI Cyprus National Platform that is under the Federation and is help the patient advocates to enrich their knowledge about research. We have education, also under EUBADI CY. We have participation in decision-making and control, which means that we are participating in each group or in each ad hoc committee for all the discussion about health. We have equal participation with health professionals, health agencies, drug agencies, and health administrations. And we have also patient advocacy in groups. The transparency of the process of appointing the representatives in the above-mentioned bodies and committees in order to ensure both the relevance of each project and the plurality of representation. Undertaking training activities for their representatives, which means that we are making a lot of trainings in order our representatives be educated and be correct. We have several meetings per year. And for example, last Saturday, we had a whole day education about pharmacies. And we are trying to be as much as educated and to have a very strong voice and opinion when we are going to each committee. We have to deal the doubt of the knowledge. So we have to be ready and educated to be an equal person on the discussion. Yeah. This is what I was talking about. We are making a lot of educational workshops on health economics, on communication strategy, on exchanging the good practices. We join AFPA and a policy workshop with biologic and biosimilars in the context of the new NHS. And as I said, we have UBADI national platform, which is under the Federation of Cyprus. The board president is Suzy McCree, and it's the responsible body for the education and training of patient advocates. The first workshop that we made, it was on the drug development, the fundamentals of drug discovery and development. And the second workshop, it was about the patient representative who participate in decision-making committees. So we need patient experts in order to be there and in order, as I said before, to have a strong voice. But we have also challenges and risks. And I wanted to add that in order to make you to understand how we participate. For example, I participate on a scientific committee about physiotherapy for children with neurology problems. I use Stalo, for example, is participate on the subcommittee for physiotherapy for musculoskeletal conditions. And they are invited us, and we have to be on the meeting, we have to be prepared, we have to know what's going, the agenda, and we have to be ready and know what's going on. And usually we have a meeting every month on this committee. And maybe we will discuss for a treatment, how many therapies, for example, if you have a hip replacement, how many therapies should the person has. And we are producing protocols, we are taking decisions about this, and then our committee will go to the higher level and will show what we want to implement. Or, for example, with medicines, with biologicals and biosimilars. I've been a lot of times on the committee of pharmaceutical services and now of the health, national health system, and we are going there to discuss if a new biological treatment is gonna be on the system. And I have to know all about this, and I have to read and understand what is doing this treatment and how we should and why we should implement in the system. So we need a lot of study and a lot of effort to be on these committees, but at the end we have better health system. Mm-hmm. So we have to face the challenges and the risks. We have objecting an evidence-based view, confrontation with patient stereotypes. We have the factories, I know everything, I am the top. We have the interference and the corruption that we have to be very careful who are represented us and who are these people and where I come from, not from Portugal or from, yeah, what is the background of the people? We have to face the failure to respond and adequacy a lot of people they are coming and they want to be part of the group, but a lot of them they will not stay. We have to face the funding and the financial support because in order to be educated, we have to have support, financial support. And we have to be careful with ambition people and springboard to achieve personal goals, because we are not all willing to do things without taking anything back. And we have to be very careful. The benefits of participation is designing patient-centered policies. The focus is on the individual and their unique needs. Active participation of citizens, that they are the system users. Better understanding of needs and prioritization. Interaction between technocrats, politicians, and system users, that sometimes we cannot understand them. Improving the impact and quality of health policies and the quality of life of individuals. This is our main goal. Better management and allocation of available resources. Transparency, efficiency, optimal use of resources. The participation of OSAC representatives, as I said before, it's a member of OIE board. OIE is the National Health Insurance Organization. Drug Pricing Committee, Medicines Committee, and ad hoc committees, Medicines Advisory Committee, committees of Ministry of Health, National Committee of Digital Health, committees of National Health Insurance, physiotherapy, occupational therapy, psychology, and all other committees. National committees like the National RMD Committee, National Cancer Committee, Rare Diseases Vaccine Committee, etc. And Parliamentary Committee on Health. Whenever the Parliament is discussing about health, they have to invite a person from the Federation. And they have to send the agenda and all the details about the topic. Participation in the Advisory Scientific Council of State Health Services Organization, participation by representative in the Scientific Council of Mental Diseases, appointment of representative to the National Committee for the creation and implementation of protocols and guidelines, participation in a working group for the capacity planning project within the framework of the National Health Service, coordinating group study of public health services, utilization and client satisfaction for the State Health Services Organization, representative on working group list of minimum health data, representative on working group assessment of health needs. So we have a lot of committees, a lot of meetings, lot of everything. So the support and the participation is the cost project, the life. It's some project that Federation is negotiating and it's working on. The cost project, Life Media Project, Prestige, Cyprus, Run Care Cost, Integrated Precision Medicine Technologies Research Center of Excellence, ECO Project, Virtual Coach for Healthy Aging, IRIS, Bayer, CY Biobank. Conclusion, participation is the hard way. Decisions to be on the part of decisions, this is not very popular. We have configurations, we have co-responsibility, because when you are participating, then you have also on your shoulder the how we call it, the cost of the decision, because you are part of the decision. we have to balance contracting vs advocacy, because when I am there in a committee, I mustn't think Andri as a user. I must think that Andri is a representative of 1,000 people. I mustn't think what is my best for myself, the best thing, but I have to think what is the best for the rest of the people. And so we have a contradiction on our head, and sometimes we have to step back and think again and be very careful what we are saying. And we have the danger to become part of the system, because you are there with them many times in a month or in a year, and you are starting to see the things from from their scope, and you have the danger that you will be part of them and you will not focus on what is good for the patients. And maybe you will think that, okay, they don't have the money, so I have to step back. It's, for example, it's a money issue. But you have to have in mind all the time that you are representative of patients. And of course, before we go, we are asking the patient organization, the members of the federation, if they have anything issue, if they have something to tell us to negotiate. Thank you.
Thank you, Andri. It was really inspiring, and yeah, we can talk later, I think, because we don't have time.
Yeah,
So
I will be here.
I'll invite Anna for our closing remarks. It was good if we had time to discuss, but maybe...
Okay, whatever
yeah.
you want to ask,
Okay.
you can ask me tonight and tomorrow. Yeah. And later on, I will not disappear.
So it's been a very long and intense day. I can imagine you are all very tired and drained. So I will make it really brief. The good news is we seem to be back to a new normal. We're overcoming a governance crisis with a new Agora. We're overcoming a pandemic crisis, and we're back face-to-face again with the conference and meeting and the networking. And I guess we can all agree that there's a line that connects all the presentations throughout today that tell us that we are here, member organizations of Agora, as well as all other stakeholders, the pharma companies, as well as the public institutions, to take care of each other and to make sure no one is left behind. Close cooperation is key. Collaborative work is the way forward, and we are all here to work together. Of course, open dialogue should prevail, as well as transparency. And tomorrow we start at 10 with a session into the future. Have a good rest, have a good dinner, and please show up tomorrow. I hope you survive till then. Thank you all.